This is one interesting case, and this will give us an insight about how the refractive correction or refractive surgeries are useful for patient. So this is one particular lady who had a refractive error of minus 23 diopters. This is the anterior segment photograph, and this is the posterior segment photograph of the right eye. And we can see that there's a staphyloма around the optic disc. However, her fovea macula are not yet atrophied or involved in the staphyloma, or chorioretinal degeneration has not yet set in. And this is her UB2 sheet, the universal Barrett 2 formula used for IOL power calculation. And initially we had planned her for phakic IOLs, but finding that the AC depth was uh, surprisingly shallow because it was less than 2.8 millimeters. And so it was rather surprising because usually myopes have a deep AC. And this is the reason why the UB2 formula is very useful in these eyes, because it actually takes in the consideration for the effective lens position and gives you a better predicted target reflection and the IOL power required for that. So this is the UB2 sheet, which predicts the IOL power of minus 8.5. So this is a negative IOL, negative power IOL. And as you can see, the target refraction for 1.5 diopters or 1.25 diopters was considered good for this patient, because myopes should be left behind, slightly myopic if they don't have any accommodation left behind. So the target, as for this kind of target refraction, the SRKT predicted minus 5 diopters of IOL power. However, the universal Barrett 2 predicted minus 8.5. And by the company's limitation of production, they couldn't manufacture this in trifocal or bifocal, and only hydrophilic monofocal meniscus lens was available for this kind of power. It was a customized lens, and IOL power of minus 8.5 couldn't be manufactured by the company. So we finally decided on the IOL power of minus 9 diopters. So this was about the same in the other eye, which again had uh, this is the fundus of the left eye. And again, the universal Barrett 2 predicted similar situation. The phakic IOL was not possible. It was not possible to have a hydrophobic multifocal or trifocal IOL. So ultimately, we had to go with monofocal IOL, and that to a hydrophilic design. So target refraction of minus 1.25 or minus 1.5 was targeted, and the IOL power predicted for this was minus 8.5, and we had to use minus 9 because this is what was available. Now, usually I do my capsulorhexis in these patients under very, very low illumination with retinal illumination on, because these patients are young patients and they have so much aversity to bright light, especially the myopes. So it helps in the cooperation of the patient. And that is why you can see the capsulorhexis is being done in a very, very dim light. And it's even difficult to see it on video. However, once you do hydrodissection, then you can ramp up the light, because now the lens becomes opaque and these patients are relatively comfortable. So, and more so, if you ramp up the light, you can actually control the whole scenario with the phaco probe. So even if the patient is not cooperative, you can actually do your surgery. You don't need a side port because these are all very soft cataracts. There's no need for any nuclear disassembly, and the bulk of the nucleus or the lens matter is gone. There's hardly any nucleus, and then you switch to irrigation aspiration cannula to remove the finer filaments of the lens cortex. Placing in the hydrophilic monofocal IOL, it's a negative power IOL as we have just decided, and it is something like minus 9 diopters. Placing the IOL in the bag, and because this patient also had a corneal astigmatism of minus 1 diopter, so flattening of 0.5 by 1 incision, and additionally placing another incision. This is the other eye, and because we did both the eyes in the same sitting, so it was a sequential surgery, one after the other. So in the meanwhile, the other eye which was operated, which is the The right eye was patched for a while, and the surgery was done for similarly for the other eye, taking care that there's low illumination at the start till we have done the hydrodissection so that patient is comfortable and able to cooperate well. Usually, I believe that the BCVA cannot be improved in these patients. However, to my surprise, there was a significant improvement in the visual acuity. And as I have told you, the right eye was improving to 6 by 60 with correction of minus 23 diopter of spectacles. And the left eye also needed minus 23 diopters, but the visual gain was something 1 by 36. So we had actually counseled the patient that you will get rid of glasses, but the vision will remain the same. That is a very safe bet because you cannot predict how will be the vision at the end of the procedure finally. So we have removed all the lens matter and now goes in the hydrophilic monofocal meniscus lens of minus 9 diopters. Once the IOL is dialed into place, we remove the viscoelastic and also place opposite clear corneal incision, and this will take care of the astigmatism. And the surgery is done. And the best part is that we had a surprise in the sense that patient improved to 6 by 12 in the right eye and 6 by 18 in the left eye, from 6 by 60 in the right eye to six finger count and 1 by 36 in the right eye. And this is a pleasant surprise, and this is because the myopic lenses of such high power also cause minification of the image, and this translates into a lower BCVA. However, when the appropriate power lens is shifted inside the eye, the minification effect of the lens is gone. And that is why the images increase in size and patient has better vision. And this is one very, very useful surgery and a very, very satisfied patient. Thank you.